Okay, so we will go with the percussion today. So somebody had drawn some red and yellow lines. I don't know who has drawn. So can you erase them? Yellow, red, because I will not be able to write on them. That is causing some problem here. Okay, so percussion, most of the time what happens in your cardiovascular system is percussion will not be given that much importance because of the two things what are there. One is most of the time the patients will be in atrial fibrillation. So if the patient is in atrial fibrillation, you will be giving an explanation that there may be underlying like cardiac thrombus or like a clot might have been formed within the atrium, and that's why you will not be doing the percussion because of the risk of dislodgement of that clot, and it can cause systemic embolization, not the pulmonary emboli. So remember, it will cause systemic embolization, causing your coronary artery will not be usually affected, but it is the carotid, like through carotid, it will go to the CNS. It could cause your systemic embolization, like your mesenteric embolization or renal artery embolization, or it can go to your upper limb, lower limb, and it can cause peripheral, like gangrene, and it can cause necrosis. That's why the risk of embolization is high. So percussion is not done. This is the explanation most of the time you give. If the patient is in just a tachycardia or he is in just normal heart rate, he is not having any atrial fibrillation, or the patient is in atrial fibrillation and like the examiner tells he is well anticoagulated now, he is in atrial fibrillation since many months. Okay, the examiner tells you like he is having 2D echocardiogram has been done, there is no clot. Now you show me how do you do percussion. So there are different methods of percussion which are followed here. So what are the three are? One is called as direct percussion. The second one is the indirect percussion. Then third one is your ausculto percussion. Okay. So this is direct percussion. What you are going to do is you are going to do it on the clavicles as well as on the sternum. Okay, this is you are going to directly percuss. So for example, what is there? If this is your manubrium sternum and you are having here manubrium sternum, and you are going to directly percuss over the bony prominences like this, and you are going to look for whether any dull note is there, and also you are going to palpate like percuss over the medial ends of the clavicle. Here also going to directly do the bony percussion, not with like finger or anything. Directly, if this is the clavicle, directly you are percussing on the clavicle. If this is the manubrium sternum which is there, directly you are percussing on the bone like this. So if you are able to feel any, like find any of the dullness, then it could like underlying some mass or thing is there or enlargement is there, that is going to cause. So most of the time in supine position when you are doing, the whole of the sternum is usually resonant. Okay, if you percuss in the supine position, usually whole of the sternum is resonant except for some small area around the zippy sternum which can be dull here. Only usually this part is dull. Other than that, usually it is resonant. Okay. So this is the normal percussion. Okay, here if it is usually it is normally it is dull. This is the normal phenomena which you are going to get. So indirect percussion is what you do with your plexor and pleximeter. Okay, like your RS percussion, what you are going to do. So you are going to keep your finger in the intercostal space and you are going to percuss. So this is what you are going to do in indirect percussion. And one more thing, there is something called ausculto percussion. So what you are going to do is, if this is your sternum and if you are zippy sternum, you are going to keep your stethoscope here and you are going to take a pen or some stick, something like that. And you are like, if this is your rib, okay, we will take it as rib, and here is one rib and here is one rib. Okay, these are the ribs which you have, and this is your cardiac border which is present here inside. Okay, so you are going to start percussing like this with a pen, like this, just go on percussing. Okay, and you're keeping on auscultating here with a sound. So when there is an underlying cardiac tissue starts here, the intensity of the like sound which is coming, like it will be like something like resonant or some sound is going to come for you, and that is going to suddenly change in its intensity as you cross the cardiac tissue here. So something you have got in your abdomen examination also, in case of ascites, puddle sign and all, you are going to keep a stethoscope and you are going to draw a line like this, and you are going to identify where is the fluid ring which is present like that. The similar way you are going to do in case of cardiac. This is the ausculto percussion method. So in case of your indirect percussion, what you are going to do, you are going to keep one finger like this. So you are having fingers like this, and you are going to percuss on the middle finger or phalanx here, and you are going to do. In case of direct percussion, you are going to directly percuss on your sternum or on the medial ends of the clavicle. So you are going to percuss here. So this is your direct percussion. This is your indirect percussion, which is you are going to do here, and with the stethoscope and like pen or pencil, you are going to scratch like this, and that will be part of your ausculto percussion. These are the three methods which we are using. Next, coming to finding out of the right sided cardiac border. Okay, so what we will do is we will take here a sternum, and this is your zippy sternum which is there, and your diaphragm is somewhere like this. It has gone down here, and you have got a liver which is here. So what you are going to do, as your tidal percussion method is there, you are going to do, so you are going to do the tidal percussion in the mid clavicular line like this. Okay, so mid clavicular line you are going to percuss, and you are going to find out the liver dullness. Usually it will be in the 4th or 5th intercostal space. Okay, you are going to percuss like this, and you are going to find the place where you are going to get the dullness of liver border. Then you are going to get one intercostal space above. You are going to go like you just move one intercostal space above, then start percussing inwards towards the sternum. So like this. So if you are percussing like this, then you change your direction. Sometimes like you can go parallel to the sternum, or you can keep like this only and you can go. But usually preferred method is you go like this, because the parallel percussion should be parallel to the organ to be percussed. So this is your heart which is present like this, and this is your base of the heart, like your great vessels go like this. So this is your atrium and all. So this is the anatomy which you have. So if you are able to percuss the dullness which starts from the sternal margin only, like if you are going to get that, so it is most of the time it is the normal size of cardia, that is right sided enlargement is not present. If there is a right sided like RV or RA enlargement is there, like most of the time it's RA not RV, RA enlargement is there, rarely RV also. RA enlargement is there, you are going to get a dull note on percussion just like lateral to the sternum. So right lateral also around 1 centimeter also, if you get dull note, then it is called like right sided enlargement, that is RA enlargement is present. Okay, this is your right. So what is there? So this is your sternum, and your zippy sternum you have, and the cardiac border should coincide with the sternal margin. This is normal. Okay, if it is enlarged like this, so this is RA enlargement, even 1 centimeter also it is enlarged. So this is the percussion method. So first you are going to find the, like this is diaphragm, you are going to find the liver border, and going 1 centimeter above, one intercostal space, sorry, not 1 centimeter, one intercostal space above, then percuss medially and find out the border of cardiac. Coming to the left cardiac border. So left cardiac border, what you are going to do, you are going to take this as a sternum, and you are having your cardiac tissue like this, and this is your mid clavicular line. Okay, so mid clavicular line you have here, and you are going to first palpate for the apical impulse. Okay, you are going to first palpate for apical impulse in the same intercostal space. This is the intercostal space now. So this is a rib like this here, and this is the rib like this here. So it is the, we'll take it as 5th intercostal space. So if you are going to find apex in the 5th intercostal space, you are going like up to mid axillary line. Okay, you are going the same intercostal space, then start percussing backwards. Okay, from the axilla you come backwards like this. And if you are able to like correlate the dullness at the level of apical impulse only. So if your palpatory apical impulse and your percussion wise dullness which starts at the apical impulse, if they both are coinciding, usually the cardiac enlargement has not occurred. If the enlargement is there, usually like this, if the pericardial effusion, for example, okay, if there is a pericardial effusion which is there, usually those do not match with each other. And actually, whether the cardiac tissue is really enlarged or not, it is sometimes very difficult if there is associated lung pathology. Okay, it's very difficult. But usually, the most important thing is we should be able to differentiate pericardial effusion and apex beat. Usually, this is the method we are going to use, because underlying lung pathology may be cause for your dull note anywhere around the cardiac tissue. Sometimes it may not be able to actually delineate the cardiac margin, but you will be able to make out most of the time. So this one you are going for left heart border. Next, coming to your, we'll start with directly. This much is about percussion. Okay, percussion we do not have any much important findings here. And another percussion area, what we are doing is your left second intercostal space. Okay, left second intercostal space and right second intercostal space you can do percussion. So here left second intercostal space, it is due to pulmonary hypertension or it is due to pulmonary artery dilatation. So these are the two main causes which we get here. So in case of right, in case of so left intercostal space, and in case of right intercostal space, aortic regurgitation, aortic aneurysms. So usually these we have causes where we have right sided intercostal space, second intercostal space just lateral to the sternum, we can have dullness. So we can give these two as additional causes, like in percussion you can comment. This is more important. Usually we do not do this one. This one we do not do. We do on the left sided, like second intercostal spaces percussion we are going to do. Next, we'll directly start with the auscultation. So there are some basic questions they may start during your auscultation. Like these are not actually academic point of view very important. They'll ask you like what is like who discovered stethoscope, like Lennox. Then what is the diaphragm diameter, like 2.5 centimeter. Like what is the length of the tubing which you are going to use in the stethoscope. Like how they are going to ask you regarding BP machine, like cuff and length and breadth of the cuff. What is the diameter it should be there, how much it should encircle your arm, like 2/3 it should cover, over the artery it should be, some things like that they are going to ask you regarding stethoscopes. Like I think it is given in your book starting, you just remember that Lennox was the person discovered the stethoscope, and what is the diameter of the bell of the stethoscope, and what is the diameter of the diaphragm surface, and what is the length of the tubing. I think these are the basic questions that you ask you. And directly we'll start with the areas of cardiac auscultation. Okay, so we'll start with your manubrium sternum like this. If it is there, then we'll have sternum and your xiphi-sternum. So this is your first rib. Okay, one's first, and your second, and this is third, fourth, fifth, and sixth like this. So if you have a cardiac tissue like this, okay, so we're having something like this. So first we will start with our mitral area. Okay, 1 second. Okay, first we will start with the mitral area here. Okay, after that we directly move to the second area, that is tricuspid area. Then third one we will go it at here at the neo-aortic area. Then we will go fourth one at the aortic area. Then fifth one like a pulmonary area, sorry, pulmonary area. Then if we go for the aortic area, then we will go for the carotid sub. Okay, so this is your mitral area. Then we have got here tricuspid area. Then we have got here aortic, pulmonary area. Then we have got here aortic area. Then we have got your neo-aortic area. Then additionally we have here Gibson's area. Then we have got lastly the carotids. So these are the areas. So first one we are going at the mitral, then tricuspid, then we are going at the what is it? Neo-aortic area, then we are going to pulmonary area, then we are going to at the Gibson's. Like Gibson's is only if you are suspecting in the PDS, we are going to do it. Then you are in case of aortic severe pathology, neo-aortic areas and aortic areas, and the carotid areas for the radiation of the murmurs into the carotids. Usually in the aortic stenosis patients, you are going to look for like radiation of the murmurs into carotids. So these are the usual areas which you are going to look for auscultation. So here important one are only for us are 1, 2, 3, and 4 are the first primary importance in your auscultation you are going to do. If something is there, you comment about like primary areas 4, and if something is there, then you comment about neo-aortic area, Gibson's area, and carotids. Okay, otherwise simply don't start by yourself like those things and again land up into some strange questions again related to those. They may start asking somewhere not related to UG syllabus. They'll usually go. That's why don't start them like in your primary areas, only do with the first 4 areas. Next, directly we'll start with the, like apart from this, we don't have like any other specific basic terms to be started with regarding auscultation. Directly we can start with your heart sounds. Okay, first heart sound, second heart sound, third heart sound, and fourth heart sound. So these heart sounds per se, S1 and S2, regarding clinical aspects, they will be asking you much. See, for example, even if you ask me regarding the physiology book, whatever the S1 and S2, they give the differences like some subtle differences like which cardiac cycle it exactly coincides with and all those things. Like actually we are also not that much aware of. That type of questions will be asked to you if you fail to answer your clinical basis basic questions. Okay, like which isovolumetric contraction and all those things, so many are there. So actually we also, as a part of physicians or medicine books, we do not go into those. So many some differences are there with S1 and S2 in your physiology books. Usually those questions are not asked in the medicine, but if you fail to answer these, they'll try to go back to those physiology basis like questions, and they may try to ask you regarding S1 and S2. So we have like S1, we have got loud S1, and we have got like normal S1 and loud S1, and we have got like variable S1. Okay, so like these are the different terminologies which we are going to use while describing your heart sounds. So S1 is usually a mixed frequency sound. It is neither a low frequency nor it is a high frequency sound. So it's a mixed frequency sound caused by closure of the like atrio like AV valves. Okay, atrioventricular valves. So it is you are having your mitral valve and you have got your tricuspid valve. So closing of this is going to like causing your S1 is like this. So actually theoretical point of view, while describing, they are telling S1 is having actually two components like S2, but we don't tell. So that is a M1 and T1 we call them, like mitral valve, and like how we have got A2 P2, we have got M1 T1, but this is only for theoretical purpose. If they ask you are there two components, if they specifically go there, you tell there are yes, there are two components M1 and T1, but always auscultated as single. S1 is always a single sound. It is neither a split, nothing is there. Usually we tell it as single heart sound. Okay, because this is too small gap is there. We will not be, human ears are not that they are not capable of differentiating the two different sounds. Okay, coming to the main mechanism of like loud S1. So why we are going to get loud S1? So different factors are there. One is the anatomical integrity of the valve. So anatomy of the valve. Then second one is cardiac contraction. Okay, second one is cardiac contraction. Then third one is the heart rate. Then fourth one is the chest wall condition. Then you can also put lastly as volume status of the patient. So these are the different conditions which are going to cause your loud S1. Okay. For example, anatomically, what are the things which are responsible for loud S1 are like not complete calcification, no calcification or partial calcifications can be cause of your loud S1. Completely calcified valves are not going to cause loud S1, only partial or no calcification. And there should be anatomical integrity should be maintained. For example, in case of mitral regurgitation, they are not going to coapt, they are going to open up on the opposite side. So integrity should be normal. Then third one is there should be no other abnormalities like perforations of the valve or dehiscence of the valvular apparatus. Example, in case of infective endocarditis, what happens is we'll have perforations or perivalvular abscess, we describe them. They'll cause disintegration or like they'll cause instability in the valvular motion. So those should not be present. So if these all are like normally maintained, and if there is partial or like usually no obvious calcification or partial amount of calcification, usually what to tell is normal people can also, I'll describe in the next part, so it will be here. Okay, we'll not confuse with here. Then second one is cardiac contraction. Cardiac contraction is force of contraction is always like important for causing loud S1. If the patient is having like myocardial infarction, dilated cardiomyopathy, ischemic cardiomyopathy, or if he's having myocarditis, the force of contraction will not be that good. So it will not be causing your loud S1. Okay, it will be normal S1 or like subnormal like loudness. So it is like soft S1. So it is the force of contraction which is important. Then coming to the third one is the heart rate. So what is there is, if there is a tachycardia, okay, there is loud S1, increased S1. So how heart rate and PR interval are involved. So PR interval of ECG, okay. So if there is a short PR interval, okay, short PR interval indicates there is a tachycardia. So it is like PR interval is like short PR interval will lead to increased S1. Okay, tachycardia causing any condition. It could be fever, anxiety, hyperkinetic state, cytotoxicosis, a pregnancy, anemia, whatever it is. So all the tachycardia causing causes will cause increased S1, and long PR interval or it is bradycardia. Okay, these are going to cause your shortened S1. Okay. Then one more thing is third condition, like here one more thing we forgot, anatomy. Here it is regarding the state of the valvular apparatus just before the ventricular contraction begins. Okay. For example, if they are like very close to each other before closure, they may cause low S1. Or if they are very far away like this, they may also cause low or soft S1. Okay. Soft S1, not low, soft S1 it is. Soft S1 could be caused here. So if they are at adequate amount of distance they are maintained, and they are able to close with a proper like force, then only they are going to cause loud S1. Okay, otherwise loud S1 is not possible. Then whatever is there, we have got one more thing is we have got chest wall conditions. Chest wall conditions, we have got like obesity, like extremely muscular person, or there could be emphysema, and your what is it, hydropneumothorax, pneumothorax, like massive effusions, pericardial effusions. All these conditions can cause your low or soft S1. So low loudness or soft S1 can be there. And next one is volume status. So volume status, how it is like, for example, if the patient has increased venous return, okay, if the patient has increased venous return, that is going to cause increased ventricular volume. So this is called increased ventricular volume. This increased ventricular volume will, what happens is like there is a cardiac dilatation is going to happen eventually. So cardiac dilatation is going to happen, and that is going to cause far away valve leaflets like this. So there is a dilatation and it is going to cause far away leaflets. So it is going to take like lot of time for that to coact, or sometimes it could be associated with a functional regurgitation like this, because the valvular apparatus is like controlled, like its anatomy is maintained by the ring which is there. So because of the dilatation, they are not able to coact properly like this. So they'll just open up in the opposite side. So that can also be cause for your reduced sound intensity, that is low soft S1. And it is like if your venous return is low, for example, normal patient only will take it. Normal patient is having decreased venous return. Okay, if decreased venous return, there is a reduced ventricular filling. Okay, so reduced ventricular filling, like ventricle, if it is too much less, then efficiency is lost. If it is like little less than the normal range, then the force of contraction becomes invariably more for that less volume. So it is like invariably more force of contraction is there, and that's why it is going to cause increased S1. So increased venous return is going to cause your low S1 or soft S1, and if it is decreased venous return is there, then it is going to cause loud S1. So these are the different conditions we are going to get with respect to your S1. Okay, so as a summary, if you want to do, we'll make it as S1. Okay, we'll make it as S1. As a summary, like what are the causes for your loud S1? So in case of what happens in during mitral stenosis, we forgot only this one I will tell. So mitral stenosis, what happens is there is like thickening is there, thickening of the valves is there, minimal or sometimes no calcification can be a possibility. And then what happens is there is no excess of opening will be there. No excess of opening of valve is not possible in case of stenosis. So adequate force of contraction, like adequate force of contraction is like adequate spacing is also maintained between the two leaflets. So adequate force and spacing is almost necessary, like which is required for your loud S1 is available. So these are the different causes for causing loud S1 in case of mitral stenosis. Other loud S1, as we described, it is due to increased heart rate, like all tachycardia states could be there, and it is due to anemia, thyrotoxicosis, and all those. And in case of mitral valve prolapse also, you can sometimes have loud S1. Okay, loud S1. And in case of soft S1, we have different conditions. Like if we take soft S1, we have got LV failure is there, dilated cardiomyopathy is there, then you have got ischemic MI or like myocardial infarction, and you have got extensively calcified valve is there. That is not going to cause your loud sound is not possible. So all these, and you are having a bradycardia, decreased heart rate, and you are having increased venous return, conditions with increased venous return. All these are going to cause a soft S1. So these are the different conditions with which you have to differentiate. Then third one and last one will go with a variable S1. So variable S1 is because there is a varying PR interval or heart rate. Okay, PR interval and heart rate, there is a variability, and this is the first condition. Then second condition, there is a what you tell, force of contraction is also varying. Okay, force of contraction is also varying. So for example, if you are having atrial fibrillation, there is always variation with respect to heart rate or PR interval. So with a short PR interval, if any beat is coming, then it's going to have loud S1. If it is a long PR interval, that is going to have a soft S1. This is one. Then in case of force of contraction, what happens is in case of premature ventricular contractions are occurring frequently, or if there is a AV dissociation with complete heart block. So if this is there, then you are going to have PVCs or like premature ventricular contractions, or there is a dyssynchrony between the SA node impulse and the ventricular impulse. So there is going to have a volume deficit. For example, a beat has occurred with SA node and there is a long gap for the next ventricle beat to occur. So a lot of volume is there in the ventricle. So there is a soft S1. If there is a small, if there is a SA node beat which followed by shortly, there is a ventricular contraction. So there is a small gap which has been formed. That is going to cause low volume, and it could be low, like reduced ventricular dilatation, and it can cause your normal or loud S1. So there could be a variable force of contraction, variable volume status, and variations in the pulse rate and heart rate. I think the session is going to end. We'll give you one more link. It is less than 1 minute.